Traumatic brain injury is a common emergency. This lecture aims to clarify concepts in traumatic brain injury and discusses the pathogenesis of various clinical manifestations and also the rationale of management. Terms head injury and traumatic brain injury are often used interchangeably. However, head injury implies an injury to the calvarium or the skull base. An immediate traumatic brain injury might not have occurred, but in some cases, like in an extradural hematoma, you will find that a head injury with a fracture might result in a delayed traumatic brain injury because of secondary compression of the brain. So you can say that head injury and traumatic brain injury may be concomitant. Sometimes it can be delayed, or in the case of a chronic subdural hematoma, it may be delayed over days or weeks. There is also another condition of traumatic brain injury, which is a cumulative injury, commonly found in boxers, football players who are exposed to repeated head trauma. Mode of head injury can be the commonest is a vehicular accident, two-wheeler accidents, accidents involving pedestrians, four-wheeler accidents, and even train aircraft accidents will result often in a head injury. Falls are another mechanism of head injury. Infants and children fall. Infants fall from the cot. Children fall while playing. Young adults may fall in work-related injuries. The elderly are also prone to head injury. This can occur because of imbalance, orthostatic hypotension, vestibular disorders, and even posterior column dysfunction, which is very common in old age, can result in falls. Sports can result in acute head injuries, and as we discussed, it can also produce cumulative traumatic brain injury. Other causes of head injury include assault, blunt injury, and both injury with sharp objects can also occur. War injury involves both missile injuries and blast injuries. The mechanism of injuries, of brain injury, is basically divided into two main groups. One is impact and the other is inertia. Penetrating injuries, perforating injuries are also other mechanisms of injury. Impact injury affects the surface more. The scalp may be injured, the skull may be fractured, and there may be gray matter. Cortical injuries are more common in impact. Surface hematomas, like extradural hematomas and subdural hematomas, may occur. Inertial injury involves axonal ruptures, more common than cortical injuries in inertia. Acceleration, deceleration injuries produce inertia. Diffuse axonal injuries have been graded by an Adams classification. Grade 1 is more common in the gray-white junction, more close to the surface. It involves either a complete rupture at one extreme or just an axonal stretch. Grade 2 axonal injuries are found close to the corpus callosum. Grade 3 involve the brainstem. The pathophysiology of traumatic brain injury may involve a primary injury to the neurons, which can be because of crush, laceration, or even because of hypoxia. It can involve a primary injury to the axons. Axons can stretch. There can be internal disruption of an axon, or there might be a complete injury to an axon with a retraction bulb formation. Microvascular ruptures because of trauma are also a primary injury. So you can have neurons getting involved, you can have axons getting involved, and you can have microvascular ruptures. Secondary injury occurs because of increased intracranial pressure. It can also occur because of herniations. Seizures and infections are also causes of secondary brain injury. Increased intracranial pressure may be because of edema, hematomas, or because of hydrocephalus. This occurs because of the cranium is a closed cavity. Any increase in the volume of intracranial contents by edema, hematomas, or hydrocephalus results in an increase in pressure. When the pressure increases, the cerebral perfusion gets impaired, and you have a decrease in the cerebral perfusion pressure head. Herniations of the brain occur because there is compartmentalization of the brain. There is a falx cerebri in the midline which separates the two frontal hemispheres. You have a tentorium cerebelli which separates the occipital lobe from the cerebellum. So herniations can occur either under the falx to the opposite side, in which case it is called a subfalcine herniation. It can occur through the tentorium, usually from superior to inferior, in a transtentorial herniation. And you can have a foramen magnum herniation where the medulla is being pushed down through the foramen magnum. Seizures, again, can be classified into immediate, early, and delayed. We'll come to that later. And infections might also produce injury. Coming to increased intracranial pressure, how does increased intracranial pressure compromise the brain? Mean arterial pressure minus the intracranial pressure is the cerebral perfusion pressure head. A cerebral perfusion pressure between 50 and 150 millimeters of mercury is called the cerebral autoregulation range. Cerebral edema is the primary cause usually of increased ICP after a traumatic brain injury. Cerebral edema can be cellular, that is, the neurons, the axons, the astrocytes, they swell, and this results in increase in intracranial pressure. Cellular swelling occurs because of a failure of the cell membrane pumps. Aquaporin channels open up. The sodium pump fails. The second mechanism of cerebral edema is interstitial edema. Here there is an opening up of the blood-brain barrier. Hematomas can occur with an increase in the intracranial pressure because these are acting as intracranial space-occupying lesions. Hematomas which produce intracranial pressure, increased intracranial pressure, can be epidural, often occurs in skull fractures with adults. In children, epidural hematomas can occur even without a skull fracture. Subdural hematomas are crescentic in shape inside the dura and outside the arachnoid, outside the brain via arachnoid. You will find a subdural hematoma. Intracerebral hematomas are spheroidal in shape. Hydrocephalus after a traumatic brain injury can be communicating or it might be obstructive. Communicating hydrocephalus occurs because blood in the subarachnoid space clogs the arachnoid granulations, resulting in an increased volume of cerebrospinal fluid. Obstructive hydrocephalus can occur because of small clots which block the ventricular system. After craniectomy also, hydrocephalus is common because the CSF absorption pathways get impaired. Usually CSF moves along the subarachnoid space to the arachnoid granulations because of brain pulsations, which are effective when the cranium is closed. Once there is a decompressive craniectomy, there is no closed cranium to provide a counterforce to the brain pulsation, and CSF flow gets deranged. let's have a quick look at the herniations. You can have a herniation under the fox to the opposite side, which is called a cingulate herniation or a subfalcine herniation. This can result in a clinical manifestation of contralateral monoparesis because the anterior cerebral artery, which courses over the corpus callosum, can get kinked. You can have a foramen Monro block because of a subfalcine herniation, resulting in a dilatation of the opposite side lateral ventricle. Transtentorial herniations are also called uncal herniations because the medialmost part of the temporal lobe, the uncus, herniates. This produces a dilated pupil on the same side. This is because the third nerve, which is carrying the parasympathetic constrictors of the pupil, is getting impinged upon by a descending uncus. Midbrain compression can produce compromise of the corticospinal pathway, resulting in a contralateral hemiparesis. And if the whole midbrain unit shifts across to the opposite side, the tentorial edge can produce a Kernohan's notch, which results in an ipsilateral hemiparesis. The posterior cerebral artery, which is a branch of the basilar, which supplies the occipital lobe, can get kinked as it arches over the tentorial edge by a descending uncus. This can produce an occipital infarct, resulting in a contralateral visual field loss. Foramen magnum herniations occur because of medullary descent. It can result in vasomotor instability and ataxic breathing. It's a pre-terminal event. Now, basically, herniations produce symptoms not just because of pressure, but because of vascular stretch and vascular compromise. That is why herniations are so critical. Coming to post-traumatic seizures, these can occur early, immediate, or it can be delayed. Immediate seizures occur within 24 hours, attributable to an excitotoxic surge, electrolyte disturbances, calcium buildup. This occurs within the first 24 hours. From 24 hours to 7 days, you have early seizures. These are attributable to a failure of lateral spread inhibition. Lateral spread inhibition is by inhibitory interneurons, which function suboptimally because of metabolic failure after trauma. Once they recover, this phenomenon comes to an end. Delayed post-traumatic epilepsy has got a different pathogenesis. New synapses which form might produce circus rhythms or abnormal repetitive circuits which can result in seizures. And this is also the reason why post-traumatic epilepsy occurs. So immediate and early seizures can be aborted and prevented by anti-epileptic drugs. However, anti-epileptic drugs do not prevent the onset of post-traumatic epilepsy. You can suppress them, but the epileptic circuits persist. The physical features of traumatic brain injury include the features of skull fractures like raccoon eyes or battle sign, which is a bruising over the mastoid, or even skull-base fractures can produce CSF rhinorrhea or otorrhea. Paradoxical rhinorrhea can occur in a middle cranial fossa fracture where CSF comes through the eustachian tube into the pharynx. Consciousness, the loss of which is a classical feature of traumatic brain injury. Why does loss of consciousness occur? It is because of a stretch of the brain stem. The ascending reticular activating system in the brainstem gets stretched and the patient's consciousness gets impaired or lost. Consciousness is basically a brainstem function. Awareness is a thalamic function, and the recording of memories is a hippocampal function. So all of these can be lost. A person can become unconscious. A person can be conscious but not aware of what is happening. Or a person might just have post-traumatic amnesia where he's not recording events. Loss of consciousness can be quantified by the Glasgow Coma Scale, devised by Janet and Teasdale in Glasgow Hospital. Eye opening from 1 to 4, 1 the eyes don't open and 4 eyes open spontaneously. Motor M1, no movement. M6 is a person who obeys commands. Verbal response V1 to V5. All these I, E, M, and V scores have got confounders. Eye opening will be impaired in head injuries where the eyes are swollen. Eye opening may spontaneously occur without really having a positive effect. In coma vigil, a person who is in vegetative state might have spontaneous eye opening and even roving eye movements. Motor response cannot be assessed in a person who has got a spinal cord injury, and then there might be a focal motor loss in a brachial plexus injury. Verbal responses cannot be assessed once a person is intubated or he's got a tracheostomy. Speech again can get impaired because of a cortical aphasia. The Broca's area is affected. Post-resuscitation GCS is important. So a person who comes with a very low GCS should be resuscitated, oxygenated, and given adequate fluids for his circulation before you prognosticate based on GCS. Pupillary asymmetry is one of the important features that you look for in a traumatic brain injury. Pupil size is maintained by a balance between sympathetic and parasympathetic activity. Sympathetics come from the cervical spinal cord and follow the vessels. Parasympathetic activity is arising from the Edinburgh-Westphal nucleus. You have parasympathetic fibers which travel along with the third nerve, go to the ciliary ganglion, and then act upon the constrictors of the pupil. So the reflex pathway starts from the retina along the optic nerve to the tectal nucleus to the Edinburgh-Westphal nucleus, that is the parasympathetic nucleus, along the oculomotor nerve to the ciliary ganglia, short ciliary nerves and iris sphincter. So when you shine a light in the eye, if the visual pathway is intact, you will find that the pupil will constrict. There are two kinds of reflexes that you look for. A direct reflex is when you shine a light in an eye and the pupil on the same side constricts. This is a direct reflex, means an intact optic nerve and intact third nerve on the same side. This will also produce the opposite pupil to become smaller because the Edinger-Westphal is common to both, and you'll also have a contralateral reflex. If a pupil does not constrict even with direct or with indirect or a consensual light reflex, the oculomotor nerve is impaired. If you find that the pupil does not constrict with the light shown in the same eye, but will constrict when the light is shown in the opposite eye, the third nerve is not involved, but probably the ipsilateral optic nerve is involved. So a dilated pupil can be because of uncal herniation. It can be because of an optic nerve injury. It can be because of an oculomotor nerve injury or a compromise because of an uncal herniation or a bleed along the oculomotor nerve, which is often seen. Or it can be just because of traumatic iridoplegia, a direct impact to the eyeball. The clinical features which you often find in head injuries include motor deficits, psychiatric disorders which are manifest as the patient's consciousness improves, because the cortical effects will result in a psychiatric disorder. Consciousness will improve once the brainstem function is restored. Vision loss, always look for it. Monoocular loss is because usually of an optic nerve injury, very often associated with anterior skull base fractures. A field loss is usually because the optic radiations may be compromised, by an intracerebral hematoma, or an occipital infarct because of an uncle descent. Diplopia suggests that one of the external eye movement nerves has got compromised. We know which are the nerves. LR6, that is the lateral rectus, is supplied by the sixth nerve. SO4, superior oblique, is supplied by the fourth nerve, and the other muscles of eye movement are supplied by the third nerve. Petrous fractures may result in facial palsy and hearing loss. Other cranial nerves which may be involved in head injury include the lower cranial nerves and the hypoglossal nerve. When we talk about clinical features of traumatic brain injury, we should learn to distinguish between the features of hemorrhagic shock and the features of increased intracranial pressure. The features of hemorrhagic shock include tachycardia, tachypnea, hypotension, oliguria, cold clammy extremities, and obtunded sensoria. In a head injury, you'll find the patient has got the Cushing's triad, which means bradycardia, hypertension, and respiratory irregularities. Essential head investigation in a head injury is a CT scan of the brain, along with a cervical spine screening, especially in more severe injuries, because severe head injuries, which are usually described as a GCS of 8 and less than 8, are often associated with cervical spine injuries, up to 10 to 15%. Chest and abdomen may need to be evaluated by a polytrauma series, but if the person has got no features of a chest injury and no hypotension, an X-ray chest and a FAST, that is a focused abdominal sonography for trauma, may suffice. MRI, the indications include spinal cord injuries, and optic nerve injuries. Coming quickly to management, primary importance is keeping the airway clear and ensuring adequate oxygenation. If a patient has got a Glasgow coma score of 8 or less than 8, endotracheal intubation and positive pressure ventilation are indicated. IV fluids which are given, usually we give normal saline. In the very young, we normally give dextrose normal saline. IV mannitol is given in a dose of 100 ml 8 hourly routinely. Higher doses can be given, 0.25 to 2 gram per kg body weight. Phenytoin sodium was the drug which was preferred as an anti-epileptic, given in a loading dose of 10 to 20 milligram per kg at a rate of 1 milligram per kg per minute, and then a maintenance dose of 5 milligram per kg per day. Levetiracetam is now slowly replacing phenytoin sodium as the anti-epileptic of choice in most emergency rooms. Role of steroids is very limited. The CRASH trial showed that the corticosteroid rescue in acute severe head injury trial showed that the outcomes were actually worse in patients who are administered steroids. Steroids, of course, methylprednisolone is given in spinal cord injuries, especially cervical spinal cord injuries, where there is no other chest injury or no comorbidity like diabetes. Surgical treatment aims at optimizing the intracranial pressure. Hematoma evacuation is one aim, the other is a decompressive craniectomy, which increases the volume of the cranial compartment. In an extradural hematoma, there might not be much cerebral edema or no edema at all, in which case you can just do a craniotomy, evacuate the extradural hematoma, and then keep the bone flap back. In most cases where there is associated cerebral edema, you would do a decompressive craniectomy along with hematoma evacuation and duroplasty. Is there a role of decompressive craniectomy for brain edema without hematoma in severe head injuries? There has been a study called the DECRA, which showed that the outcomes do not significantly improve. It is a multi-centric study conducted in New Zealand and Australia. Other surgical procedures which may be useful in traumatic brain injury, which may be required, include anterior cranial fossa repairs for CSF rhinorrhea and shunt procedures.